Thank you, Alan. I see I'm getting close to recruiting you onto the MSc. A few more presentations and I'll get you on the coach to Ypres. I want to introduce you to this hidden atrocity, hidden until about 2000. It occurred during the Korean War in 1950 when a group of elite troops, the 7th Cavalry, slaughtered a group of civilian refugees who were hiding under that railway from attack. And the justification at the time was that the troops had been briefed that they were communist infiltrators. And this was all hushed up in the way of things until 1999, when a US press report brought this to the attention of the world. The South Korean government then conducted a major inquiry and established the horrific nature of what had gone on and the fact that it had been perpetrated by US troops. And then Edward Daly came along. Edward Daly had got himself the post of unofficial historian of the 7th Cavalry. And once this event had been publicized, he then started to write about it and talk about it from the perspective of a participant and saying, you know, this is something had traumatized him. And now was the time to talk about it fully and to, apologize. And in May 2000, he makes the journey to No Gun Rai. And I should say, I've got a South Korean student. When I said No Gun Rai to her, she started laughing for about 5 minutes. So I can assume that my pronunciation is definitely not right, and I'm probably swearing, so forgive you for that. She won't tell me the correct pronunciation. Anyway, Edward Daly goes back, and here he is, photographed apologizing on behalf of the 7th Cavalry to the survivors of this awful disaster. And he comes across as a man who's traumatized with humility and understanding. Sadly, none of this is true. He was never there. He wasn't in the 7th Cavalry at the time. He didn't participate in the shooting. His army record showed that he was a clerk and mechanic, an ordnance maintenance company, miles away, and didn't join the 8th Cavalry for another 8 months. So why on earth would somebody do this? Why would you falsify the fact that you had taken part in a horrific atrocity? And this has sort of stretched people's sort of thoughts and imaginations. One of the things it seems to be that he was trying to create a false biography of heroism, that he claimed various decorations for the period before the atrocity. And he would go to regimental reunions and he would go up to people and say, "Don't you remember me? I was there. I was the one who pulled you out when you were being attacked." And people say, "Well, I'm not sure it was you, but I guess it was." And so it was partly to do with establishing a false biography. Okay. But he's not the only one. We've got an example here from CBS television, The War Within. So this is a television program some 12 years before Daly's account, where three of the 6 Vietnam veterans claim to have committed horrific atrocities. So Steve Southards, a US Navy SEAL operating behind the lines, killing and mutilating Vietnamese civilians and children. But again, detailed research well after the event by Burkett and Whitley showed that in fact he was an internal communications repairman. He was nowhere near what was going on, never took part in any combat in Vietnam. So again, why on earth would he do this? Why would he go on television and admit these horrific things? This is very different from this example, which is the fabrication of not being a concentration camp guard, but actually being a victim of the Holocaust. So this is Bruno Grosjean, who wrote this award-winning biography, got lots of prizes, Jewish Book of the Year award, until it was worked out that he was actually born in 1941, lived the entire war in Switzerland, couldn't possibly have been involved in any of these events. So what I want to look at is it's an idea that historians have talked about since the 1930s. It's the Whig interpretation of history. And the idea is that we've moved in very smooth progression from sort of poor understanding of events where we struggle to really grasp nuance and liberal interpretations. And as we go forward through time, we add through research and greater understanding, so we come to this position where we really have an in-depth, thorough understanding of psychological events. So we can apply this to our growing understanding of trauma. And so the argument would be something like shell shock in the First World War is very crude, people made a mess of it, they shot people who they couldn't possibly diagnose correctly. But now, with all our research and knowledge, we've really got the edge on them, and we've come a long way and we should be pleased about it. And if we apply this to the First World War, we can see at the beginning of the war that, sure enough, it looks about right. Troops were coming back in 1914-15 with medically unexplained symptoms, with tremor, anxiety, and everyone was trying to work out what was going on. There was no diagnosis at that stage to cover what would now be called acute stress disorder, combat fatigue. And there weren't the psychiatrists there, military psychiatrists prepared and ready, and they came back on general trains with the wounded, and they were treated in general wards by physicians who were trying to make sense of these presentations. They call in an expert because this is really important. The war's going to go on for years. It's a war of attrition, and if you can't treat psychological casualties, then you're going to run out of men. So they call in the top man of the day, Frederick Mott. He's a neuropathologist. He's done a lot of work on GPI. And he sets up his laboratory over the road at the Maudsley, and he starts with a grant from the MRC to look at these cases of shell shock, to try to understand what's going on. And obviously he starts from a sort of organic perspective, that these are either post-concussional cases or they're toxic exposure. And there he is, a wonderful photograph in the Maudsley in his laboratory. As he goes on, he sees large numbers of patients because the Maudsley becomes the receiving centre for shell shock in the UK. And it's a war of attrition, and by the end of the war, he's seen upwards of 12,000 patients have passed through the doors of the Maudsley. And what he does, by the summer of 1916, his understanding of this disorder has moved on appreciably. He says by then the number of people who've got genuine concussive disorder or a toxic exposure is very, very small. It's probably 10 or 20, it's certainly not 20% of the shell shock population. The vast majority fall into this second group of people who've got psychological vulnerability. They're people you can see in their pre-service life or in their family history were vulnerable to the awful effects of trench warfare, where you're seeing your comrades killed and horribly wounded. And they established this later in the war by doing a trial where they compare servicemen with gunshot wounds of a similar age and rank. They compare them with their shell shock cases, and they note that there's a significant increase in psychiatric family histories in the shell shock group. So they've established that there is vulnerability to breakdown. But this is the bit that people generally miss out. He also identifies a third group. These are people with no vulnerability that they can see, no family history of mental illness, who are physically and mentally fit before the war, but who break down because they've exposed to something that is so terrifying, so awful. As he says, even the strongest man will succumb. So by the end of 1916, having seen so many cases, Mott has reached a position very, very similar to what we would take today in terms of PTSD. He's got notions of pre-service vulnerability, hereditary upbringing, and he's got a dose effect. He studies how often people have been wounded, what battles they've been through. And he uses that to design his treatment regime at the Maudsley. And he goes for this idea, the atmosphere of cure. He wants to engage patients in their own recovery. He thinks morale is the key to getting men back to activity. So he focuses on the things he can control. High-quality food, lots of fresh air, control of exercise, control of infection, graduated exercise. Everything is designed to make the soldier feel better about himself and keen to return to military duty. The officers are given better quality. I always used to think the photograph at the bottom was the medical officers. They're actually officer patients in a high-quality building at the top of the hill. And you can see his treatments are pretty non-invasive, continuous baths, and he avoids psychoanalysis. His approach is very much, your traumas, we'll deal with your trauma after the war. We'll put it to one side, get you functioning first. And he raises money. Lady Bentinck is there, persuaded to donate money for a big building which he can start occupational therapy. And he encourages soldiers to grow vegetables in the garden, in the grounds of the Maudsley. That's partly to increase the quality of the food, but also to give them something constructive to do. So it's almost a therapeutic community. And this is translated in the interwar period into the Maudsley itself, the Maudsley's civilian practice. So what happens, we think, is that war creates large numbers of casualties in a very defined group, which allows specialists like Mott to study them in great detail, and he will pick up differences in pattern. And of course, the military is very good at standardizing procedures, so he has a significant throughput of patients of a very similar type, which enable him to make these precise judgments. So just a pause, really, to say what shell shock is, because in the media it's always described as being a synonym for PTSD, and it certainly isn't. Shell shock is a catch-all term. It emerges in 1914-15. Soldiers talk about it themselves. It's a term that is invented by troops in the front line to describe how they're feeling. And it's not until February 1915, that Charles Myers uses it in the Lancet in the first medical publication and gives it the status of an official medical diagnosis. So you can see it covers a huge range of symptoms. Some cases of PTSD, we've looked at about 400 randomly selected cases of shell shock, and within those you'll find about 10% meet the criteria for PTSD. But most of them are psychosomatic, medically unexplained symptoms. So, of course, it has something in common with MTBI, which is said to be the signature injury of Iraq and Afghanistan. There's the MACE screen instrument of 2008, and you'll find a lot of those symptoms occur regularly in shell shock cases. So there's a bit of an overlap with MTBI, and there's publications in America saying you've got to take MTBI seriously because we saw it in the First World War as shell shock, and that's one more way of just demonstrating how important this is. And the third element, which has emerged in the last few years, is moral injury. And if you look through, again, lots of cases of shell shock, every so often you'll come across somebody who meets the criteria for moral injury, the sense that you've been wronged, you've done something wrong, you reflect on the war and you think, ethically, I didn't train to do this is not what I believe in. And of course, this is Siegfried Sassoon, probably one of the most well-known examples of moral injury, who takes his military cross ribbon off and throws it into the Mersey in disgrace and writes the letter to the press condemning the war. So, and the rationale for moral injury, why it's become so important now, is partly the results of Steenkamp's critical review of treatment for PTSD, where here you can see that 60 to 70% of veterans, when treated with recognized NICE guideline, CBT, still meet the criteria for PTSD. You get a reduction in the number of symptoms, but they still meet the criteria for PTSD. And the same thing is true of studies done at combat stress, where the vast majority, 70, 80% of veterans go through the intense treatment program, they improve functionality, but they still have the diagnosis of PTSD at the end. So the argument is that there's something being missed in these veterans, and moral injury is put forward as the bit that at the moment is not being tackled. So if we move on to the Second World War, again, we've got the same conditions we had in the First World War. We've got large numbers of psychological casualties. We've got increased numbers of psychiatrists because psychiatry has moved on in the interwar period. And it provides, again, another significant opportunity for research. But there's no change in the causal theories. Personality remains absolutely fundamental. And here's Henderson and Gillespie writing in 1962 saying, even in 62, what we're saying is if somebody breaks down on the battlefield, the primary cause is your personality. War is merely the trigger. And that's designed to explain why, if you have 1,000 men, 100 will get shell shock. Why did the 100 get shell shock and the 900 don't? And they're always saying the first thing to consider is personality. The Southborough Committee in 1922 was set up to learn the lessons from shell shock, and they came to the erroneous conclusion. They made a big mistake. They thought that you could prevent breakdown in the Second World War. They thought if you selected people, trained them, gave them high morale, you would more or less eliminate psychiatric breakdown. And you can see the Royal Air Force and the Royal Navy, which had a very high selection procedure, didn't bother about psychiatric provisions going into the Second World War. They think, we won't have them. They'll all be in the army where they take the people we reject. But what is exposed in 1943-44, huge numbers of well-trained, high morale men and officers in elite units break down. And by then it's unavoidable that if you subject people to the killed and wounded rate, the more killed and wounded, the more psychiatric casualties you'll get. And this is the York Clinic at Guy's Hospital, opened in 1944. And that was filled with casualties from Normandy and from the Royal Air Force of bright young men who had broken down and were really severely crippled by their traumatic illnesses. And the director, Robert Gillespie, published the first paper in the BMJ, which uses trauma in a psychological context. What happens then is, in the immediate aftermath of the Second World War, the Americans have got the resources to do significant research into breakdown. And what they discover is they've got evidence from Normandy, and they analyse admissions to the neuropsychiatric units very near the battle, very near the beachhead, and they discover that if you expose men to 60 days of combat, continuous combat, day after day, 98% will have broken down by the end. No one is immune from the trauma of this intense, protracted, killed and wounded. But this wasn't known in the Second World War. This is knowledge which arises as a result. And the other thing they establish, which is very significant and continues to dominate military psychiatry today, is the enduring association between the killed and wounded rate and psychiatric breakdown. The only way to avoid psychiatric casualties is never to go to war. Here it is that they've established it by looking at different theatres and seen that there is always the link between the two. So battle intensity is the crucial variable. This is really just to show that this message can be applied across cultures, across wars, different timescales. So there's some results here from Yom Kippur. So these are publications by the Israeli Defense Force, just to show there that at the beginning of the war, a war of surprise, when the Israelis are taken by surprise, they're not prepared, their psychiatric casualties are higher than their physical casualties. And then once they get the battle under control, start winning, so the psychiatric casualties start to fall. But in a sense, I think what this evidence does, it begins to lay the ground for PTSD, because it's beginning to establish statistically that the crucial thing is not your personality, but the weight of casualties. The Israelis are beginning to show that what really determines breakdown is the number of troops who've been killed or wounded, and that really moves the argument towards PTSD. So PTSD, when it comes in 1980, manifests 4 significant changes. It reverses those causal variables. War is no longer the trigger, but it's criterion A. The rights of the individual increasingly take precedence in trauma over duty towards the group, and I'll talk more about that. Stigma is reduced because the individual is no longer primarily responsible. And the 4th thing is secondary gain, the mysterious disappearance of secondary gain. I remember ward rounds in the 80s and early 90s. Secondary gain was mentioned for every other patient. But now, that's sort of, again, dropped off the agenda. And it's interesting that in 1980, criteria A was pretty loose. Most people would meet that. An existence of a recognizable stressor would evoke distress in almost anyone. You could almost measure me before I came in here and I'd get criterion A. But by 1987, they've tightened up a bit, made it a bit more tricky. It's not so easy to meet that definition. And of course, every time a new DSM comes out, criteria A is the one thing that goes through a lot of changes. So, this is almost like a multiple choice question. On what basis was DSM admitted to PTSD admitted to DSM in 1980? The answer, strictly speaking, is number 3. Numbers 1 and 2 come along, but they're not really around to provide sufficient evidence before 1980. And it's really a campaign by veterans and psychiatrists to reverse US foreign policy that drives PTSD and its admission to DSM-3. And I'll explain what I mean. The problem the anti-war campaigners had with the Vietnam War is that formal psychiatric casualties were really low, less than 10%, less than 5%. The Americans invested a huge amount of resources into psychiatric treatment in Vietnam. So it was very difficult to criticize the government on the basis of its provision of service in theatre because they poured resources in. Psychiatric breakdown rates were very low. So the anti-war campaigners could only really expose the government by saying, you're missing it. What you've got to do is look at the troops when they come back, look at the veterans, and you'll find that's when they start to suffer with delayed stress syndrome and post-Vietnam syndrome. So their campaign focused on returned troops and transition. And they enlisted, which was unusual, they enlisted the help of Jack P. Smith, who's a decorated Vietnam veteran, and he's also a news correspondent, so he's media savvy. So he's a warrior and he's connected with the media. And he's important in their campaign to persuade Nancy Andreasen, who's chairing the committee, to include what becomes PTSD. Initially, they want to call it post-combat stress reaction, catastrophic stress disorder, but her view is that it's got to be more generally operationalized. It can't be a disorder that just relates to Vietnam veterans. It's interesting, Robin Murray this morning showed a picture of Nancy Andreasen with some horses, but I thought maybe it's better to show her with some scans of brain scans. And of course, she was originally, Robin told me this, a professor of English long before she became a psychiatrist. But she was sympathetic because she'd done research with Burns patients and she'd seen the same pattern of symptoms. And so it is readily persuadable to include PTSD. But what is interesting is it takes a long time. It's at least 10 years before PTSD is accepted in the UK. The Oxford Textbook in Psychiatry in 1986 doesn't mention PTSD. 6 years after it's been admitted to DSM-3. And I remember going to, the first time PTSD was mentioned in a ward round in Guy's was in 1990. And we had a patient, elderly woman in her mid-70s suffering from appeared to be depression. She had repeated admissions. Nobody could get anywhere. And the consultant said, I know what it is. She's got PTSD. Everyone just sort of laughed and said, but she's not a Vietnam veteran. And he said, no. I think she's got PTSD because, where does she live? She lives in Bermondsey. It's got poor social housing, there's gangs. It's like living in a war zone. None of us were convinced. We thought, that doesn't make sense. Surely that can't be right. First use of PTSD. But actually, he was right, but not for the right reason. Because a few months later, she had another admission to the ward, and I thought, I'll go and talk to her again. I've known her for quite a long time, so I was attached to the same ward for 3 or 4 years. And I had a long chat with her, and she said, I said, what's happened in your life? And she said, well, of course, I grew up in Bermondsey, and I was living in Bermondsey during the Blitz. Oh. And in about 1940, I was at home with my parents. I was about 15, 16 years old. A bomb fell on the house. One of my parents was killed. I was dug out of the rubble. And she'd never told anyone this story. So in a way, he was right that she had this primary, horrific, traumatic experience, but never talked about it. And all the time, we were sort of looking at the depression attached to PTSD and never really getting to the root of the problem. The sadness of the story, of course, is we didn't have an effective treatment to offer her at the time. These are some of the events in the late 1980s that contribute to the acceptance of PTSD in the UK. So there are 2 transport disasters and 2 terrorist attacks. And these start to get people thinking that PTSD is applicable to the UK to a range of patients. So the Herald of Free Enterprise, significant deaths, and is written up in journals. People are interviewing and conducting research into survivors. At this stage, they're talking about the symptoms, but they're not giving the label of PTSD. Again, King's Cross underground fire, same thing, significant mortality, lots of trauma, papers published, no reference to PTSD, although all the symptoms of PTSD are being collected. Enniskillen bombing, again, horrific event, gets into the press, and now PTSD is being reported. So you can see it gradually coming into the literature. And the final one, of course, Lockerbie plane crash. Everyone on the plane is killed, but the people in the town have been traumatized by the event, and PTSD rates are recorded as very, very high initially, but then falling to 15% in follow-up studies in the early 1990s. So this is a sort of change of direction. In the first half of the 19th century, when we're talking about shell shock, PTSD breakdown is described very much in terms of groups. It's not about individuals. So Wilfred Trotter, he's a surgeon I know, wrote the key book, Instincts of the Herd in Peace and War, and it's based on his experience of observing people in the First World War. And he says what happens in war is that we have an innate instinct of gregariousness. We're drawn together in times of hardship. And you can see this in the Blitz, where people, share things, cook for each other, actually just become more engaged. And he says homogeneity is the thing that protects you. That's the thing that stops you having a breakdown. And it's when you're heterogeneous, when you're spread out, you're at risk of psychological injury. And this is one of the reasons why armies are successful, seem to be able to cope with trauma in wartime more than civilians. And this informs public policy in the Second World War, because planners, knowing that the Blitz is coming, are very nervous. They assume the civilian population will crack because it doesn't have these protective factors. And I was looking this morning at a paper by Brigadier James, published in 1955. He was the senior medical officer, senior psychiatrist in the Western Desert, and he writes up his experiences, and he says, the only way you can understand breakdown is to look at the function of the group, about soldiers bonding together to protect each other. And often breakdown is related, the timing of the breakdown is related to the destruction of those bonds. And of course, treatment is seen in group terms in the Second World War. Fuchs, here he is, Fuchs is this guy here. He'd been in the German army in the First World War. He's responsible for setting up these small, successful groups towards the end of the war, where he's saying the breakdown is essentially because the soldier has some issues with the group that he's involved with, so the appropriate way to deal with it is to set up group psychotherapy. And again, in the post-war period, dealing with transition, groups are seen also as crucial. And it used to be argued that the lower levels of psychiatric breakdown in the immediate post-Second World War period was because we were all much more communal. The bowling alone idea, that people were members of large numbers of social, religious, sporting organizations. And the fact that people in London and the major cities had been in war meant that they had some understanding of conflict. And so veterans returning after the Second World War would feel in a sort of general therapeutic community where people were more accustomed to sharing and talking about experiences, and that facilitated reintegration. I suppose this changes. The argument is that this changes, that sort of corporate, duty-driven, deference society is replaced during the time of Thatcher, when there's an increased emphasis on the individual and individual rights. And then you get, she says something like, there is no such thing as society. And we saw that reflected in two court cases where we had 500 veterans suing the Ministry of Defence for negligence in the treatment and detection of PTSD in 2002. And everybody knew involved in that there were more court cases coming behind. The RUC one follows in 2005, but we knew that had those cases been won by the plaintiffs, there would have been other emergency organisations, other groups coming forward seeking compensation. And there was nothing like that in the immediate aftermath of the Second World War or the First World War. One effect of the decline of the group and the increase in psychological understanding, is the reduced value and applicability of the term cowardice. And cowardice used to be the most damning criticism you could make of any soldier. And the most damning thing that any soldier could do was to desert, because essentially what you're doing is you're saying, you, the group, not interested in you, I want to stay alive, I'm off. And I don't care if someone else has to come and take my place. So in both world wars, the most severe punishment is weighted out to somebody who deserts, because they are seen as favouring, they're putting their own individual rights ahead of the duty of the group. With the gradual growth in psychological understanding of trauma and the creation of new diagnoses, so beginning with shell shock, and then in the Second World War we have battle exhaustion, combat fatigue, and PTSD, the space for cowardice has been gradually eroded, because we can explain a person's behaviour in terms of what they've done, where they've come from, the amount of training they've got, and cowardice no longer applies. You can see it beginning here in the immediate post-war period. In 1949, Stouffer's major study, The American Soldier, where servicemen themselves who'd been through combat have a greater willingness to accept the impact of battle on a person's behaviour. And you can see here the instance of the word cowardice has really gone from being a very popular word now to being hardly used at all. And any soldier that would stand up and call his man a coward would really be making a serious risk in terms of, how that's perceived and actually the morale of his troops as well. So troops today they're still not happy about desertion, but it wouldn't be described in terms of cowardice. And in fact, that's had a change. The whole idea of the deserter has been reclassified. It's no longer seen necessarily as shameful or a bad thing to do. But if the deserter can demonstrate that he's got PTSD, that he's been through a huge number of very unpleasant, traumatic experiences, the deserter can be reframed, as in this book, as a heroic figure. So the deserter can now stand alongside the warrior to get public approbation. And that's been reflected in public policy as well. So Harry Farr has been pardoned. 306 or 305 UK soldiers were executed in the First World War. And in 2001, this memorial was opened at the official Armed Forces memorial. Each pole represents an executed soldier. It's not a great design because in amongst those are murderers. It's certainly not clear that of the 305, we don't know what percentage were actually traumatized servicemen. There's a lot of people in there who actually murdered their comrades at a time when capital punishment was, affecting the whole population. And then following that, the Labour government pardons all these servicemen because of the campaign by Harry Farr's relatives. So this almost brings me back to where I started. If you can be pardoned and considered, your behaviour can be explained. If you're a deserter, it's not too far away to saying that if you're horrifically traumatized, that could explain why you've committed atrocities as well. And finally, I suppose, if you get rid of cowardice, if cowardice is no longer on the agenda, one reason why soldiers, say, fighting in Afghanistan or Iraq, would go through really terrifying experiences because they don't want to be labelled as a coward, if that's no longer something that people are using, what seems to be happening now is that soldiers on the battlefield are using psychiatric stigma as a way of buttressing their determination. And so this study by Carlos Osorio shows that levels of stigma amongst UK troops are very, very high when they're away on campaign, but when they come back to the UK, they adopt a much more understanding and lower level of a stigma. So it's almost like they're using stigma as a way of keeping themselves in dangerous jobs, because cowardice is no longer a useful variable. So final slides, really. PTSD today, there's a lot of evidence about PTSD. There's lots of neurobiological studies, there's lots of epidemiological studies, and no one doubts its validity and how useful the treatments are. But none of these really existed when it first came into DSM in 1980. And to some extent, I think its success, the reason it took off and it's flourished, is because it does strike cultural notes. There's something about the cultural direction that we've been traveling in which it fits onto and has evolved to meet them. So I'm beginning to wonder, should we go back to shell shock? This is where it sort of started. Shell shock has been deconstructed from this lovely catch-all diagnosis. It's been split up into PTSD, mild traumatic brain injury, and moral injury, and you can see how they progressively come in. And it's almost now as if the research is saying, actually, we need to put these all back together again, because the standard treatments for PTSD, when you look at veterans, don't particularly work well. Mild traumatic brain injury, there's very few treatments actually around anyway, even if you get that diagnosis. And moral injury, we're now beginning to think about what this is and how we should address it. So, Whig interpretation of history, I don't think it works. I think what people were doing in the past remains as relevant today as it was then. Thank you.